Okay. We're going to go ahead and get started with this last session, so if you could sit down, please. Oh, wow, that was so effective. You're so compliant. Wow, excellent. Well, we're on the home stretch for a long day. Many of you had travel yesterday and some of you just today, so we really appreciate your engagement and your attentiveness. And so we're going to close today with this session on patient-partnered research, unpacking its power and how to make it happen. It's kind of sticking with the theme of how, what are the action items that we're going to take from here? How, it's good to have opportunity to brainstorm and talk, but let's talk specifically, how does this look? And we recognize in some of the talks that we've had today that this really continues to be kind of an evolving recognition of the value of partnering. I think that we've got this excellent panelist group here today that are going to give us some really concrete examples about how valuable it can be to partner with patients in planning research. However, sometimes we're still at a point where people, and I go and meet with different groups, and they're like, well, yeah, we get it, it's important, but how does that really look? What does that really mean? Both from patient perspective as well as from a research perspective. There are a couple concepts I want to just briefly speak to. When we talk about patient-partnered research, are we talking about patients? Are we talking about patient advocates? And I know that within SPAGN we've had conversation, and our colleague Ornella has been writing a paper on trying to make sure we define clearly, are we looking, not all patients are patient advocates, and not all patient advocates are patients. And what are we really looking for in a project, and what voice and what perspective do we need? So being sure that we understand that when we're partnering together is going to be critical to the success. And in like fashion, oftentimes people say, well, I want to bring the patient voice, or I want the patient perspective, like it's singular. And sometimes for some projects, yes, you do want that kind of N of one, an individual perspective, but other times you want to have the spectrum, because not everyone with a certain subtype of sarcoma experiences it the same way or has the same priorities. And so that's where the patient advocacy community can be really helpful to bring together that collective voice and collective patient perspective. We have an excellent group of panelists. You've heard some of them speak already today, and they each have had some excellent opportunities to be working either as a patient advocate or patient with researcher, or researchers working with patients to partner in research. So it should be a lively discussion, and they will have some time to share perspectives. We want this to be interactive. We want to engage you and hear your ideas and your thoughts as well. And so, kind of keeping with our theme of being kind of action-oriented, these are the goals that we hope that you will all be able to walk away with by the time we end this session. That you'll really be able to list the benefit of patient advocates and researchers partnering to plan and implement research, and be able to identify what are those challenges and obstacles to partnering, and then really describe some strategies to enhance the effectiveness of working together, and then really take away some examples of good opportunities for partnering. So with that, I'm going to be done talking, and we're going to switch to our panelists. And I think that we'll just go down the line and start with you, Dr. van der Graaf, and ask you to introduce yourself. So each of the panelists are going to introduce themselves and just give us like one example of success and one key obstacle you think that exists in patient partnering research.
And you would like to focus it on sarcoma?
Well, yes, that would be lovely. Did I forget the word sarcoma in all of my discussion? Well, thank you for pointing it out.
Yes, thank you. So my name is Winette. I'm a medical oncologist, professor in Amsterdam in the Netherlands, in the Netherlands Cancer Institute, and at Erasmus MC in Rotterdam, the Netherlands. I've been working in the field of sarcoma, I think, for all my career. It's 30 years now, I think, in sarcoma, and I know many of you, so it's good to see all these well-known faces. I'm also working in the EORTC, which is a cooperative group in Europe for clinical trials, and have been leading originally there a sarcoma group years ago, and I'm current president of the EORTC. And that was also a bit related to my question to you, because within EORTC I also have advocated started more emphasis put on patients, input, patient partnership in research in general and in clinical trials specifically. So, a bit long introduction, but maybe it shapes the future.
Yes.
Do we want an example? Or,
You want an example?
Yes, sure.
Yes, it's interesting because my example was also on another tumor than sarcoma, if you don't mind, because I think it's just worth showing how important your voice can be at different stages. And more in general, when I look at the European field, we want to have, of course, we want to be as inclusive as possible, but as we are all sitting here, we can all understand English, first of all, and speak it. So when you consider such working together with patients at the European level, there will always be a possibility of having people not being involved because they don't speak English. That problem is not solved yet. When we organize things for patients, we really would like to do something with patients where they really think they benefit from. And one of the things we organize is the patient days, where we really organize for all patients, including the sarcoma patients and patient advocates, methodology workshops, all kinds of interesting talks for them. But it's based on the input, what they really want to hear there. And it's interesting to see that over the years, some years ago, the main focus was on molecular targets, for example, and people had to come there and explain. It was really interesting. And now more and more we see also a shift to emotional well-being, about the diagnostic trajectory, about also input from themselves. But it is also with living with your disease. And there is, I think, a general more emphasis on quality of life research. So what we did is also organize a project within the EORTC to see how we can partner with patients in projects where we also have quality of life as endpoint of clinical trials. And we all know that in sarcoma field, we don't have, unfortunately, after imagining, I think, the great drugs that really led to a significant increase in overall survival. So the way how you live with your cancer is becoming more and more important. I think therefore it's so good to work together, because if we design clinical trials, do clinical studies, it's good to know the endpoint that we design it together with patients, because ultimately, of course, we run trials and we do our work because of you. And I think we learn a lot of it. For example, hopefully we can have, that's interesting, at the start of trials with really a research question, I think there's a lot to win still. At the end of the design of a study, then the patient leaflet, you will understand it, is shared with patients, or happily during already the design phase. And then again and again we hear, it's really way too long. Please make it, it's even upsetting me with all these side effects. So based on their input, we have now a means to reduce the 15 pages to only 2. And make a link to all the other ones, so that you can read the most important ones that are not bothered with things that only occur in 1% of the patients, but can frighten you. These are well, it's the low-hanging fruit. Another topic, if I may say, is that, for example, in head and neck patients, we not only may have language barriers, as I refer to, but also we see that patients may feel a bit upset to be involved, because there's a lot of shame and stigma in head and neck cancers, and it's difficult to get these patients into the head and neck research group. because, well, it's maybe a more difficult group to involve. But still, my colleagues from the head and neck group want to have these patients involved. And now they are considering other ways, because where head and neck advocacy is very active on is in prevention and is in HPV, is in all habits that you can better not know, but there are patients there. So if you link with these patients who do this advocacy work and ask them to be involved in research projects, that may also help. So it's just some examples from other tumors, but in fact, it's not that difficult to see that this also applies to sarcoma patients. Even there are ideas why I get a disease. Well, I hear a lot because I'm living in the Netherlands at a part where there is the heavy metal industry, and I think it's due to the fact that I live there. Well, maybe, we don't know yet, but don't blame on you. So I think all these aspects are very important to cover, and you can only do it when you really sit together and ask what their feelings are about why you have the disease and how we have to design clinical studies with which are the relevant questions to you. So that's what I would like to say.
Thank you, Winette. Hi, everyone. My name is Bill Tapp. I'm a medical oncologist at Memorial Sloan Kettering. I treat rare cancers, ultra-rare cancers. And if you ask me what I am, I'm a patient advocate, right? That's why I get up and do everything I do every day, and why we continue to, fight for what is all important to us. So I think in my talk today, I highlighted two examples of successes. Shout out to Sydney Stern and TGCT, and she's here, so talk to her about the secret sauce of that. I also think the EAG Foundation has totally infiltrated, so many different aspects of how we should advance care for patients, right? So Denise is here, please speak to her. What I would like to highlight is an organization known as Quad W, which you may be familiar. Quad W stands for What Would Willie Want? Willie was a remarkable young man who died in his teens of osteosarcoma. And at the time, being devastated by the lack of research, the family got together and formed Quad W, and they raised a lot of money. And interestingly, Quad W, the board of Quad W, was all of Willie's friends. So at the time, teenagers who formed the board of this organization. And they, over the years, funded like $10 million that they gave out to research, which was absolutely incredible. And I remember they all brought us to Jackson Hole to have like a 10-year update of all of this funding, and they had all the world's experts sitting in a room, and the board member, which was now probably a 28-year-old, got up and said, "You guys haven't done anything in this disease in the last 10 years. We've raised $10 million, and outcomes for this disease have not changed." And that was a remarkable admonishment of what we do in academic medicine. And so we sat down and said, how can we do this differently? And the thought was that we, as an organization, because we were part of their organization, cannot just raise money to give out to people and say, focus on your work, do what you're doing, make changes. They had to become directive and prescriptive. So from that, they formed the Osteosarcoma Institute. We were just at a board meeting at the Osteosarcoma Institute, and it has been remarkable what's been accomplished. We were sitting in the room with some of the world-renowned researchers, academic, industry from around the world who years ago never thought about osteosarcoma, but now we're in that room working on projects that the Institute felt were important. And it was interesting watching that evolution over the years, because everybody in this room knows what's important for your diseases and the questions that need to be tackled. So let's put together the teams to actually do that. And just as an example, they brought together meetings with world experts about topics that were important. There were think tanks. They created relationships. They created collaboration so that now There are researchers all over the world doing work and advancing things rapidly. And one of the most interesting things that I felt that came out of this is that, there have been a lot of interest in using MYC inhibitors in this disease, as in many cancers. And MYC inhibitors were very, very difficult to get. And one of the board members just happened to see a company that was developing a new MYC inhibitor that was in Spain. So everyone reached out, we spoke to the company and said, if we fund a 10-person arm in osteosarcoma, would you do that? And they were like, we're happy to. They happened to be aligned at an institute where we have a lot of collaborators. We call them our clinical collaborators, and said, would you be interested in doing this? They said, we're in, let's do it. Within 1 year, almost from day to day of that idea, we had our first patient with osteosarcoma on trial with MYC inhibitor that is now tied with all the correlatives to this huge think tank of researchers to figure out how to iterate on that process. But it's moving the community together, and questions are important, right? That's I think, a tremendous amount of success.
Yeah, my name is Markus Wartenberg, and I'm a patient advocate now for around about 22 years. And we started 22 years ago with a pure patient organization for GIST and sarcomas, and we developed the organization over many, many years. We changed the organization now to a common organization together with our medical experts. And this is very unusual because normally you see all patient organizations, but we made very clear that our future lies really directly in the close collaboration. And that's why we changed this 6 years ago into one organization. And I think that's a step forward. We are still learning together. I think that's a process, but it makes a lot of things much easier. So I'm also involved with SPAGN in some of the projects on an international level, and I'm also I'm involved in a very fantastic, I would say a fantastic project in Germany. Or it's not a project, it's a long-term initiative, I would call it, and this is called the NCT, the National Center of Tumor Diseases. And this is a huge development in Germany in the moment, where we build up a huge structure within Germany during the last 2 years to run early clinical trials, phase 1, phase 2 trials, academic-driven clinical trials. And this is a fantastic development because from the very early beginning, it was a must that patient involvement is a part of the whole story. So we developed, together with the medical experts, we developed the whole concept of the NCT, the strategic concept. And one of the major pillars of this whole concept is patient involvement in clinical research. That means we have developed a complete strategy how we make this happen within the NCT. And we are not just talking about sarcomas, we are talking about all types of cancers. But with the support of the patient community and with the discussions with our medical colleagues, we have had the opportunity to bring sarcomas into the arena as one of the priority disease areas. I think that's one really big way forward within the structure. But also then we are now running this whole system, and this means that every new trial concept that is brought to the NCT needs to have patient involvement in clinical research from the very early beginning. And there we build up a full structure with all the details. We train patients also to be able to be part of the process. We give guidance to the medical experts, but also to the patients to move really forward with this process. And I think that's the way forward. So we need not just talk about patient involvement, and I think we will come in a few minutes about the most critical barriers of patient involvement. It's not just about talking about it, it's what we need is a cultural change within the next years, because currently we have a total different spectrum. So on one side of the spectrum, we have really highly motivated researchers coming to us and discuss early clinical trial ideas, and they want our input, and we have really fantastic collaboration and fantastic discussions in moving the trial forward. This is one part of the spectrum. And on the other part of the spectrum, we have medical experts. They think now patients want to play researchers, or now we have the dictatorship of the patients, or something like this, and this costs a lot of time to involve patients. So this is the other side of the spectrum. So currently we have a lot of different attitudes to this topic, but what we really need, and this was also part of our talk today, very early, we need a partnership, a true partnership in moving the things forward.
Okay, so my name is Gabi Ott, and I was diagnosed in 2018 with a dedifferentiated retroperitoneal liposarcoma, and then I underwent multimodal therapy in the sarcoma center, and actually almost today I'm 6 years with no evidence of disease. I was asked to participate in a research project to define research priorities on retroperitoneal sarcomas. And I was happy, and this is led by the clinic where I was treated, and of course I said yes, and I was happy to be asked and to be part of the steering group, because there is so little evidence and research and funding available in Germany for this rare subtype of sarcoma, and there are like, I think about, they told me 400 patients every year new, and a population of 80 million, so this is very few, and I know also, I'm aware that many of us would not be able to participate in such a project, so I really thought I could go to that. And I think what is really great about it is that patients and experts are represented equally in the steering group, and on top of it, experts are representing a multidisciplinary team, including, for example, nutritionists or psychologists. So that is really good. Now, as patients, we have now the opportunity really to influence what kind of issues the researchers should look into in the future, in the years to come. And I think that is, of course, really a great opportunity. And in our concrete case, it is expected that the top 10 research questions will come out in 2026, and that will be the base for future funding. So, a little bit to the challenge. I mean, this is the only project I'm involved in, so I cannot really talk a lot. But I think what a challenge that I perceive is that while there is not so much anymore question about the why. It's like everybody's agreeing that patient involvement is important, or maybe there are some discussions, but okay, that's like, it's not really a question, but the how is really still a question. I think there are still a lot of issues that need to be looked at, particularly also the practical side. I guess we're
Thank you. Hello, I'm Jonathan Fletcher from Boston, Mass General Brigham, Dana-Farber, used to be Boston Children's. My background is medical and pediatric oncology. Many think of me as a pathologist, but I'm not. I do a lot of diagnostic work, but I am an oncologist. And all my points have been covered, so I have to think on my feet. I'm standing on the shoulders of giants here. I'll relate one thing that some of you may relate to from a kind of an opposite perspective. For me, I've been a lifelong studier of sarcoma. I have a research lab where we identify new targets. We have a lot of models that we've created so we can evaluate the approaches first in cell cultures, then in mice, and move the ones that are the most promising, of course, and do clinical trials. And this has been said earlier today, I think by Bill and by others, but the most important scientific information that we receive comes back to us from the trials, from the correlative science, particularly if there's biopsies of the tumor or blood samples. And it's that kind of a laboratory where we're generating ideas and then we're refining them based on the experience. As long as we're moving forward, we're happy. Okay. Now the point that I was going to come to is that for me, it was super, super easy to go into sarcoma as a field. And it was because before I came to the Harvard hospitals for my fellowship, I was at another wonderful hospital and I was drawn to cancer. And there was a 23-year-old inpatient with synovial sarcoma who was dying of the disease. And the thing that just struck me, it was so depressing, was that nobody knew what to make of him, like of his disease and of him and the situation. It was just so beyond the usual experience for that oncology setting, even though it was an academic center. And so when I moved over to the Dana-Farber, I thought, and also I was doing pediatric oncology, where of course in kids, sarcoma is a bigger part of the overall cancer pie than in adults. But I just thought, like, here's an area that really needs help. And then I aligned myself with pathologists who were always obsessed with sarcomas because, as Bill said, all the different types, telling them apart, and that's something that they always want to improve upon. So I've found it to be an amazing field to contribute to. And what's clear is that our opportunities over the next 5-10 years are so much greater than they were in the last 5 to 10, let alone the 5 to 10 before that. You know, that like in the GIST field where we've made so much progress, we now think with a straight face about curing the disease, metastatic disease. Not for everybody, you know, that's not possible, but for subsets of patients incrementally. And that would have just seemed like a fantasy 5 years ago. So that's me. And in terms of obstacles, opportunities, I guess we'll come back to some of these. They've kind of been covered. Well, I should say that I'm the Chief Scientific Officer of SARC, a role that I love. I mention that because Denise Reinke, in her former career, was the chair of the, well, she was the chair of the board of directors, the CEO, and the president of SARC. And so to the extent that SARC, which is a national group in the US, knitting institutions together to coordinate sarcoma studies, is doing anything worthwhile at this point, it's because of Denise and all the hard work that she did over the years to move that along, okay? And I wear other hats, like everybody else up here. The one that tickles me the most right now, Markus knows this well, it's this remarkable new effort in Germany through the National Tumor Zentrum, where the government in perpetuity is putting a lot of money into new clinical trials. And oddly, I'm the head of the trial selection board, not exactly a clinical trialist. And when they called Michel Baumann to explain that to me, I said, really? You know? I said, why? And he said, well, because I said, everybody on your committee is brighter than I am. And he said, yeah, but that means you'll let everybody else talk. And that's the way I feel about this group up here. The wonderful experiences for me has been from the beginning, we've worked with advocacy groups. Those groups have, of course, funded some of the important work in the sarcoma field. And I like to work nationally and internationally. Probably everybody else up here does as well. And the advocacy groups certainly like to think in terms of national terms and international terms, and you connect with each other, just like at this meeting. And for me, that's just been a remarkably important aspect of my professional experiences, that we're connecting with scientists. I'm a basic scientist. I think in terms of biology and targets. And that's now the obstacle. The problem is, how do we bring patient advocates in a meaningful way into basic science? Like, for most of us who are in the field, it takes 10 or 15 years before you're even serious about what you're doing and you're oriented. How do you bring in somebody who doesn't have that background to contribute in a meaningful way? I know exactly how it happens with clinical trials and development, and that whole culture has changed so much in the last couple of years, importantly so, right? But how does one extend that to scientific development? How do you get people together to discuss new biological challenges without oversimplifying things for the benefit of a group that isn't as well oriented, while still getting the work done when you're trying to do serious things like cure sarcoma, right? You know, how do we bring that together? I have some ideas, okay, but that's the, not now, okay, but that's the obstacle, because I think, you know, where you've gone next level with many other challenges, we can do that, okay? But, you know, it takes some vision, I think, to really make that happen in a way that benefits all. So that would be the obstacle to work and development, I would say.
Thanks. So I'm not going to answer any of those questions. I'm filling in for Dr. Widemann. I think maybe we can get some input from some people out of the audience now. Are there ideas out there about barriers that still need to be overcome, or how we've overcome barriers, or talking about what Jonathan just mentioned, how can clinical trialists and scientists communicate what we're doing better to patient advocates? I mean, I think that's always an important consideration when you're talking face-to-face with a patient that you're trying to explain the therapy to, and in a broader sense. But how can we do better with that? I always feel like I'm not always sure I do it effectively. I'll run the microphone out to you. You can watch me jump off here. It'll be amusing.
Well, maybe does somebody have an idea? Okay, go. It's always hard to know how long you wait before you jump in. It's also that. Did you want to?
Oh, okay.
Might be now.
Okay.
Seems like a very difficult question.
Yes.
About it.
Hi, I'm not sure if this is what you're looking for or not, but I'm a member of the osteosarcoma community. My daughter was diagnosed with osteosarcoma when she was 12 in 2007. So I've been a patient advocate for 18 years now, and she's doing well. But when you ask that question about how can we better communicate, I've talked to some of the patient advocates here, and many of us interact with other patient advocates on Facebook groups. But I know there's a very low clinical presence on those groups. One of the groups that I'm a moderator for is rotationplasty. And so we get a lot of people who are newly diagnosed finding out about their surgical options, joining the rotationplasty group. So some of these groups might be good ways for folks like you, for researchers, to disseminate plain language information about clinical trials. I know there's other platforms besides Facebook that are out there, but there's still incredibly active groups. There's 3 for osteosarcoma, Ewing sarcoma, in addition to the rotationplasty. So that would be a suggestion that I have.
Pass that down. Hey, Christina. Since you passed the mic to me, I'll just follow up with that. Another, Christina, representing MIB Agents, which is another osteosarcoma organization. And specifically on the clinical trials, how to communicate question, I was actually just talking to Kurt about an example recently where we were working with a doctor who had a clinical trial plan and had a question about research biopsies and whether or not, and it's getting a little bit of pushback, I think, also from IRB on that, and had a question about would patients consent, would caregivers consent, and so we could provide some value there, right? Because we have this community of patients and caregivers. And we were able to ask them the question and poll them and kind of give them like real feedback versus just kind of talking to 2 people, or, we would actually be able to give feedback in substantial numbers on that could really help inform, either way. And in that example, people were really supportive actually of the idea, which was actually, I think, very helpful for them for rewriting their plan and resubmitting the plan. So there's an example. Can I pass?
Annie Ashe with the National Leiomyosarcoma Foundation, and we're co-founder actually with Denise and Reinke Sarcoma for Sarcoma Coalition. And we have our listen and learn sessions where we bring patients, caregivers, and and the patient advocacy groups to learn about the latest research that's happening, that's going to be opening, because we can help with recruitment. And so that's real important to us, and also the LMS Research and Review, where we have researchers come online and talk about the research that we've helped to fund, so that they can know where that research is going. And that helps the patient know that, gee, maybe I would like to be a part of that clinical trial in the future. We want to dispel myths about participation in clinical trials. So that's one of our aims as well.
Jeff Kramer up front here.
I was thinking about your question, and I think a lot of times what we need to do, and especially when it comes to talking to patients, is we got to simplify our language. We get caught into, and even I do now, because when I got into this, I didn't know anything, but I didn't know what a neoplasm was. Okay, I do now, but not everybody knows. And I think we need to simplify our language and talk, in very simple terms so that people can understand what we're talking about. And so I think that's going to be a challenge also when you think about it, because it's hard to really break it down so that everybody can understand it. A lot of people that I talk to have maybe a high school education, and then they don't have degrees. So I think it's important that we think about that and do that.
In talking with some people today, they had shared that as they were going forward with an application to the FDA, they had to outline within their plan how did they, in a meaningful way, engage patient advocates. So addressing this issue of how do we give patient advocates and patients the tools to be at the table, because more and more funding organizations are saying they have patient advocates who serve as reviewers and say, are you engaging patients in a meaningful way? And so while we all think this is so important, this kind of, how do we really do it? And to your point, Jonathan, in basic research, then what is going to be helpful, not disruptive, and useful to move a project forward? But before you answer that, I'm going to turn to Markus, because I know you, please, do you want to say something?
Yeah.
I think that's very important from the beginning, but also in the reporting of clinical trials, because what does a hazard ratio mean? And I think also for, I would say, my colleagues, it would be very helpful if we just mention the absolute benefit. So this means that you don't live, that the patients can live 3 months longer, 4 to 7 months, without progression of disease. And what does progression of disease mean? So to have lay languages and lay summaries after the abstract of a randomized clinical trial is really something that we are very keen on to support, because and it's difficult because the journals are not at that level already. So I think here it's also a way where we can team up. If patients say, well, it's interesting this trial, but we really want to have just a lay summary as well, I think they can be, their voice may be better heard than our.
We already talked a little bit about these barriers for patient involvement in clinical research, and we put some of these barriers together, and it starts with real involvement versus tokenism. I think that's a very, very important topic. The question is, what does real involvement mean? And I'm always a little bit, it's funny, if you go to other industries, like in other economic areas, for example, the automotive industry, it is absolutely normal, mandatory, to involve the the customer into the development process. That's normal, because they want to build up good products, they want to build up good solutions. So they ask the customer, or they involve the customer into the whole process within the IT industry, software industry. It's just normal, and in the meantime, they call it co-creation. But in healthcare, this is, for many, many years, that never happened, and it's getting better now. It's getting a little bit better from year by year, and it is also different from country to country. I think in the US you have much more experience in doing this, and also in countries like the UK there is an experience now for the last years. But there are countries like I already mentioned, Germany, where we are now doing this for the last maybe 3, 4, 5 years, just on a very professional level. So real involvement means really not just checking the box or ticking the box. It's not just because it's ethical to involve patients. No, at the end of the day, we need better solutions for the patients. We need more tailored, patient-tailored trials. We need more efficient processes. And my understanding is that we can contribute a lot in this whole process. And this means not that patients now want to play researchers. That's not our role. We don't want to play researchers. We want to bring the experiences of the patients, and these are very specific experience, to the process. So it's about awareness, because many researchers and many doctors, and also the colleagues from the pharmaceutical industry, they haven't realized that this is a real value of bringing the patient's experience into the room and into this process. So it needs early involvement, it needs continuous involvement. We need to build up trust, but we need this kind of cultural shift, that this is mandatory to make progress, really to come up with innovations. And we just have had a conversation some minutes ago that the traditional way how we are doing clinical trials is broken. We need another way how we do research in the next maybe 15, 20 years, how we do research specifically in rare cancers. The next topic is a lack of awareness and educations. This starts, as I mentioned before, that many doctors and many researchers don't have the idea why to involve patients. So what is the benefit of doing this? Maybe this could delay my process. Maybe it is an extra burden to do this, but it is a benefit. It's really a benefit to do this. And also from the patient community, because many patients don't have the idea, how can I contribute to this process? What is my role in this process? And we have had a discussion this morning. We need different patients on different levels in this whole process. We need patients who have what we call the patient experience expertise and bringing the patient's experience expertise to the table. But we also need better trained or well-trained patients who are really able to bring the patient research expertise to the table. So it's not every patient is the same within the process. That's the question, what are my expectations as a researchers? What are my questions to the patients? What I would like to gain from the discussions with the patients to my project? That's another important topic. We see from time to time, we see the situation that we have meetings with experts, with researchers, and then they present us their synopsis, that means their study idea, within maybe 15 minutes. And then they ask us, do you have any questions? And if there are no questions, this is a wonderful trial. And this has nothing to do with interaction or with working together. They also need to think about what are their questions to us, and we need to start this interaction on the process. We just talked about communication gaps, and one of the communication gaps is really, and you already mentioned this, is the scientific language. We are not scientists, we don't want to become scientists. I think we need really to find a level where we really are able to communicate on this level, but also, and that's why we mentioned English as a hurdle or really a barrier, because, as you know, in countries also like Germany or Italy, the scientific language is very often English. And so many patient advocates maybe are not able or are on this level to communicate in English. So we need to come down with this kind of barriers. So we need plain language communication and different other issues. The next is the structural and logistical hurdles, because very often there are now established processes of doing patient involvement in clinical research, not in the field of the academics, but also in the field of the companies. We know many companies, some of the companies are very well developed when it comes to patient involvement in clinical research, but others don't. So they need to open the companies, they really need to develop the process in doing this forward. Very often there is no compensation for patients in the whole process. This is another issue, because when we have a table, a round table of people sitting and discussing a clinical trial, all the people around the table are compensated for the work, but the patient advocates are not compensated, and this needs to be changed in the future. It's not about making money, that's not the idea, but compensation means that they are valued for their contribution. I think that's another very, very important thing we need to overcome. But also we need clear processes, and we also needed dedicated contact persons. We already mentioned this NCT process. We established in each clinic that is running what we call the Patient Research Council, we established a full-time professional, and she or he is a scientist, and the role of this scientist is something to be a mediator between the patient world and the researchers world. And this is a new job, it's a new profession, it's a new role to be something like a translator between both worlds. So I think we need to structure this in a certain way. And we also have this power imbalance. And this needs, as we discussed before, we need this cultural shifts to the topic of patients being a research partner and have an equal involvement so that we really are able to change things together.
You know, I think one of the challenges that you're faced with, that we're faced with, is that you're dealing with 100 different diseases, 100 different, passions, right? And also at different levels of organization, right? So you may have some that are starting out, some that are really been working with and collaborating for long periods of time. But I think what's unique is you've banded together under an umbrella organization, which is SPAGN, to say, how are we going to organize ourselves? And you're sitting, I think, at a really unique position to say, maybe you can define the process. Maybe you can define what organized patient advocacy means, and how you get involved in the various different diseases, how you help each other, right? How you learn from each other, and how you become, again, I'm going to use this word, prescriptive in the process. Because when you come to the table with force and ideas, things can grow and can grow rapidly. Now, the challenge you have is the same challenge we all have. We're pulled in 100 different directions. And it's hard to say, take on another level of organization, but that's what we need. So I'd even suggest developing a subcommittee where you can begin to define what these processes are, how to interact, what to expect, what to demand, how that is in the basic science world, the clinical world, and the subcommittee can include us, right? So we can help, but at least to have guidelines for member organizations and ways to help, ways to normalize language, ways to be able to introduce into moving projects, government organization, regulatory bodies, right? That is tremendous power that I think you would be sitting on to be able to do.
Yeah, and also the whole health care system is not only dependent on medical doctors or nursing, research nursing staff. I think it's also important to realize that there is a whole crowd of people behind. And what I'm seeing also often that they are not used to directly interact with patients, but because in the whole research, I would say trajectory, they are of course also involved. So it's also interesting to see whether there is a way to interact between these people who are in general very motivated and patients. And we did it once when we organized a new program for young cancer patients, and we asked someone from the administrative layer of the hospital to chair the sessions every time. And by doing that, we saw that she was spreading the news of what was going on in this patient group in her group of administrator staff. So when I met some people, they started to talk with me about the experience her colleague had with this patient group. And then I thought, okay, well, this at least worked, and this is something we can build on for a next time. So sometimes you also, it are the small things that you can have a better communication between patients, patient advocates, and everybody involved in clinical research. And I think that's important. And another thing that is also different maybe from your example in the car industry is that patients can be unwell, of course. So you need to have the, I would say, and build an expectation management that patients don't feel obliged when they are very fatigued or unwell to take part in another Zoom meeting, that they can just say, well, today is not my day, and no argument further necessary, this is it. And also, that is something you have, when you start to work together in this partnership, these are, I would say, something you have to talk to about just from the beginning, and that really helps. We have had it in a very, I would say, sensitive topic on patients, young patients with cancer, who were involved in a research project where they were all with an uncertain and poor prognosis, but we wanted to have them on board because we did a qualitative research project in asking what their needs would be and how we could help them. And what is the way how you ask the questions? How are you asking about their work? Maybe they will never work again. So how do you ask this? How do you discuss romantic relationships or fertility? And we can think we don't dare to ask it because we don't know how to do it. They can help us in framing the questions. And I think these are all ways where patients are so important. We are talking about advocacy, but it can also just be the patients that we have in our clinic who really want to contribute. And what I think maybe also your experience is, if you know that maybe your life will not be that long, you would like to bring also some meaning, and just by sitting there and giving your opinion and your experience, it can be so meaningful in whatever research we do. So we also need to make it sometimes very real and simple, and you are very welcome. Whatever you say, we are really grateful for your contribution. Do you recognize it?
Yeah.
Yeah, I just wanted to say, I think that what Mr. Wartenberg said and what Dr. Tapp said was important, and I'm glad to see that people are looking at ways to help educate the advocates. When we were Denise was at SARC, she had a class, and so we could all be better advocates for clinical trials, and we had multiple sessions, 4 or 5 sessions. We're also in one of the cooperative groups, and we've had lessons from them, 6 or 8 classes, so we could actually know how to go through a clinical trial and be an active partner. Maybe SPAGN could do something like that, where they could have, or whatever organization could do it, so there could be more education for the caregivers,
for scientific, it's a little bit more difficult, but I think for clinical trials, it's doable. And also, I've served along with some of the people in the room here on like research evaluations for funding of like the DoD, and that was an experience to try to figure out what all these different proposals were on diseases that I wasn't familiar with. So it was an education to go back and read about those. So that's a different thing. But I think for clinical trials, it's very easy. And most of the cooperative groups now are including advocates from day one. And in fact, the collaborative group we're in, the trial doesn't even begin without a review by the patient advocates, and we can have input from day one and then all the way through the process till it's complete.
And knowing who's in our, and I see Brandy's raising her hand, so I'm setting you up for your comment that I think you're going to be making, is that knowing who within SPAGN they have programs for educating patients, because as we've learned today, there are some groups that are very small, they don't have a lot of infrastructure, and so how do we, SPAGN is not just the board and our team, it's a network of our community of advocacy groups, and how do we kind of take stock of what people have put together and share it amongst our community so that we can be stronger.
Thanks, Denise. One thing I wanted to say is, yes, SFA has already started building a research training program that we are to launch probably mid-year, an online training learning system based off of like AACR's Scientist Survivor Program and other programs out there in breast cancer and others that have used to educate and build trained advocates to participate in the research space. So that's one thing. But my comment is, and it may not be the most popular comment in the room, I may be known for that a little bit, but I would say that most of us, dare I say, all of us in this room have had more than one conversation about how patients can be involved. We keep talking about it and talking about it, and I think the idea is good, Dr. Tapp, that we can build the model, but we can build the model, but the question is, are you going to uptake? Because we know, not you in particular, I don't mean to, I'm not that controversial, no, but I mean, that's the question, is we know what to do. It's, are you going to, is the community, industry, the research community, are you going to invite us to do it? And if we can just get started, we then have the model built. Anyway, that's my comment.
But Brandy, I agree 1,000%, and I keep going back to this misnomer that you guys don't have a voice, or you guys don't have a say, right? And that there are people out there who won't listen to you, or people out there who won't engage you. That's BS, because if that's happening, it has to change, right? And one of the ways to change that is to create a collective voice and come to the table and say, look, why should a government agency say to you, we need a patient advocate at the table to sit in a room and nod? You should come in and say, we're gonna sit at the room and here's what we're gonna offer you. And this is what we expect. Because you do know what to do, and your voice is the most important. So you have to, and it's why I keep saying this is not a one-sided type of thing where you need permission to be at the table. You're already at the table by the definition of why you're all in this room, right? You're the most important person at the table. We're here to help get that through, right? So it's, you need to learn from each other. You need to all contribute to the level that you can contribute, understanding that everyone is busy. But you need to begin to create the collective and the movement that demands that your voice is heard in these areas. And I think that's the strength of an organization like this, because you're coming with a collective voice. We all go back to our day jobs tomorrow, we all go back to our regular stressors, so things get diluted quickly. So how do you create levels of momentum? How do you create levels of working groups that begin to move things forward? How do you create that presence? Because if we hear that our side of the table is not listening or engaging, that problem lies with us. So we need to demand new people there. Because the only thing I can tell you is when this is done right, and I've seen it done right, we move mountains. We may not move them quickly, but we move mountains. And if we cannot move those mountains alone, you know, we need you there. It's our desperation too to say you need to be there. So engage with us in ways that, you know, you're coming to the table and saying, yeah, we're right next to you moving mountains, and you will find the right people who will listen to you, because I think the right people understand the worth of what you bring to the table.
Yeah, I totally appreciate the education efforts, and I think that's really important. I also think it's really important to just really recognize where patients add value and understand where the true value add comes from. So, like, I've certainly been involved in initiatives where you could clearly, there was a directive to have a patient advocate, and they had no idea what to do with me, and I honestly didn't know what I was doing in the room because it was like a really more basic science situation. And Dr. Fletcher, to your point about like where to involve patients in the basic science, because I don't think I can add value to that. You know, where I can add value, where I think patients could add value, are things like the patient-reported outcomes or quality of life, or how much you're willing to tolerate in treatment. Like, do you want to come into the clinic 4 times a week? Are you okay with an intratumoral injection? Like those types of things, I think we can definitely add value on. So I think it's just kind of recognizing, you know, because I can only answer the question if I feel like I know the answer. And so that's how I can meaningfully contribute. And to also go back to the car metaphor, so for example, like I'm not going to go in and tell you how to create the electrical system, but I can tell you I want my phone to automatically connect to the car when I get in, or I can tell you that the range of how far I can drive in a, you know, electrical car is important to me. And those are very important things, right, to building a successful product. So that's, I think it's just recognizing like where patients can add value and making sure you're asking them the right questions, right? Because there are some questions that I am not going to be able to answer, but, you know, ask me the right question and I can talk to you for an hour about it.
I want to put Jeff Kramer on the hot seat right now, you know, because I think it's interesting when we talk about science too. You know, I think most people in the room know the important scientific questions, and Jeff is forming this huge chondrosarcoma forum, which is amazing. And, you know, he was getting all these experts to kind of weigh in, and everyone was giving ideas, and at the end of it, you know, the question came back to Jeff and said, well, what are the important scientific questions to you? And he was like, I know exactly what to ask. Why do people die of this disease? You know, why does it go from, you know, a local lesion that's spreading some people? Why does it get more aggressive in other people, right? So they're not, you know, it's not like figure out the science of that, but how do you then bring together researching teams that can tackle that or can think about that? Maybe that's an important component to this, right? So again, you have the knowledge of what you went through with your loved ones and what drove you crazy that us as physicians couldn't answer, couldn't do, couldn't, right? You know, those are the questions that we need to tackle. So to go back to Jonathan's point, you know, the research is only meaningful if it's really affecting people. And sometimes we need to have that check too. So we can all kind of come together and say, well, labs are still going to do what labs are going to do, but maybe we can have a coalition in this disease and just look at this question. Or maybe we can find the labs who are looking at that question, bring them together and talk. Or maybe they do need some more research funding or models to do that. And that's what the Osteosarcoma Institute did. They said, like, why is this disease so complex? And how does that cell live? That came from, you know, patient advocates. And the next thing you knew, we had a conference with some of the, you know, top scientists in the world who are dealing with those problems, who are now collaborating and saying, like, how does, you know, that happen, right? This is the disease we need to look at for that. So you are empowered, and Jeff, sorry to bring you out, but I think it was remarkable how quickly you were like, bam, 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 that's it, right? And
Well, first off, thank you for putting me on the spot, but really, thank you for the plug. But I mean, for me, it came from experience, you know, because I had to live through my daughter's, you know, disease and her demise. But it came to the fact that a number of questions from that experience surfaced. So when you guys asked me that question, I did have the answers. But I also strongly believe in collaboration and pulling together all the experts. I mean, I think it's great that we're all going to get together and we're going to talk about chondrosarcoma, and we're going to talk about finding solutions. And we have a focus. And I think those are the things. And I think you challenged me to get that focus. And likewise, I'm challenging you and the experts to come up with the solutions collectively and building a collective conscious. I think we're on the same page, when we do that.
Maybe just to comment on this, and we had a discussion also a few minutes ago. That's interesting. The project you already mentioned, Gabi, do we really need to wait until doctors invite us to such a project of priority setting partnership? Or is it on our task, is it on our role as patient advocates to define the questions that really matters to the patients from the individual diseases? So we have heard about 100 diseases. And we don't have the same research questions across all these 100 diseases. We have very specific research questions from disease to disease. So I think it's also part of our homework to go back into our communities and define what are the questions for the researchers.
Lenny?
So we got a little beyond. I kind of want to add or say something I'd been thinking adds on to what Brandy said. And we talked about earlier, Bill. It would really be helpful, and I'm coming from the perspective of the Clear Cell Sarcoma Foundation, but I know that a lot of others could benefit from the same, is having you guys, you are considered, I go to the ultra rare meetings, I go to CTOS, I know who is up here, who the others look to in sarcoma, and the new doctors look to. If you guys could really promote us, those of us that we're not asking you to do it just to anybody, but when we get to know you, and we've been doing this a while, like when we did the webinar last year, one of my thoughts when we did that webinar was, oh my gosh, I've got this on tape now, where it looked like we were partnered, SFA, Clear Cell, EHE, we had all these different, the Heather from the FDA. I thought this is an opportunity now to show that we all work together, that you can trust us. Kelly, who is she's a researcher, cell biologist, PhD. She sees it all the time in our patient group. She'll text me, somebody gets on there and they're throwing something out that some doctor who's not a sarcoma doctor, but has a trial, he's pushing the patient who brings it to our group, and Kelly's like, why don't they call us? Why doesn't the patient group ask us? Because they trust us, and they know that the research and the work we're doing is good, but we don't have, I've got Denise and I've got Kevin Jones doing videos, and Andrea Hayes-Jordan has done them. She's moved on to some other stuff. But if we had all you guys, I don't know what right word, but promoting us, saying, look, and I have had some doctors do that. I'm like, thank you. Some will say, hey, there's a Clear Cell Sarcoma Foundation. You should get in touch with them. And these are doctors that I've got cell phone numbers, and they'll text me, I'm sending a patient your way. But I don't want to get doctors' calls anymore asking who they can donate the tissue to when the child dies.
But I agree. I mean, look, we're here. We're here. I've been to Dallas for the osteosarcoma. I was in Atlanta for another meeting. I was in DC for the haystack. We're here. I've been more away from my family in the last 2 months, right? But it's an important concept. Sylvia Stacchiati, Winette, we're all here, right? The problem is we all have 100 diseases that we're dealing with, and you have your important diseases.
Right.
But even coming here, so one of the things that I think we have to tackle is to say, how do we do this, right? How do we organize efforts? How do we organize experts? Because we will walk in a room with anyone at any time that needs our help. We are partnering with CTOS to say, you guys are right there, right? You know, but it's a good question to say, how do all of your important projects get a voice with the people who need to do it? How do we get more people in the community involved? How do we get more sponsorship? How do you, one of the reasons, in all honesty, that we partnered with CPOS is because we couldn't keep up with it. If we recognized one disease, 5 others were upset. If we had one award on stage, 10 others were upset. And it wasn't because we were trying to slight anyone, it was just because of what was happening. So how do we organize it so you have a collective voice with us, and we are going to be in a partnership where we're not trying to say, well, today I'm going to go to the Sarcoma meeting at the expense of EHE or at the expense of that, right? This is, I think, a serious fundamental question, because I think we don't want to be everywhere all the time. Is how do we correct?
It's a good question, and I think when Kevin Jones did the videos for us, and he talked in the video to our group. He said, "You clear cell sarcoma patients need to get together, get your data together, stick together." And that was great, but I don't know the answer. How we are doing it in the room, I see all the same people. We're always in the same circles, but how can we, like you said?
We can do a very, I would say, quick suggestion. I don't know, if I see a patient in the clinic with a lot of questions, I refer a patient with a desmoid. I say, well, there is a very good desmoid group in the Netherlands. You can go there, and I know who is sitting in this group, and I know they are very powerful in the research projects. And if he would have for all sarcoma subtypes just a name of a person whom you can refer to, this is for clear cell, this is for EHE, and this is a good group. It's not for all the patients, of course not. But that already would be a start, because then the patients are known. And it's just, I would say, a request also maybe to SPAGN to make such a whole overview, because it doesn't take time just to say, well, this is the list of the side effects of your treatment, but by the way, there's a good peer group for you, advocate group. If you are interested, reach out to them. What do you think?
I think it's a great idea. The other thing is that I think through SPAGN, you need to create initiatives that you can all contribute to, so that you're not always focused on a disease, but you're focused on moving the advocacy chain forward. So you may be in a committee that's dealing with this question, but through that, you're getting your organization's voice through. You're meeting additional experts, you're bonding relationships, you're present. So you're contributing to your disease, but you're contributing to the organization that can bridge all of this. And I think that becomes very important, because otherwise, what happens is that we are exhausting the tireless, committed people of all of us in the room, right? We need to create initiatives that are easy for people to get more people involved, so it grows and grows and grows and builds and builds and builds. But it's not all the same people who are exhausted, doing the work all the time. And I think that's what SPAGN can offer, right? How do you organize it in a way that you're really building initiatives that's creating that publicity, it's creating that level of, activity, it's creating those levels of connections. I can tell you, to Jonathan's point, about how quickly things are moving, we all need to be in this together. But I can also tell you that where we are with patient advocates, I don't make a move without a patient advocate. I have probably 15 Zoom calls a week with patient advocates about real serious projects that are moving forward on really collaborative levels. It's why we developed the PUSH program, so patient advocates are involved in every disease. This has changed dramatically over the last few years through hardcore individual efforts and people refusing to say, we're not going to let this rest. How do we organize it? Right? How does this organization come back to us with a level of organization that is just like that? We're everywhere. That's what we need. We need you everywhere. You need us everywhere. So how do we do it? Right?
Good question.
Hi, everyone. My name is Matt Shaw from Vancouver, Canada, and I'm a patient advocate with the BC Cancer Agency. I think this is a perfect time for me to jump in with an example, maybe a success story, a case study on patient partnership and how we can do it both non-specifically to sarcoma, but also as a model. And I want to just thank everyone for what they've shared in this room and acknowledge that I do agree with Dr. Tapp that we should have a model, a process for patient partnership. So at the cancer agency, I was diagnosed with cancer when I was 21, and after my treatments, I joined as a patient partner. So I heard about this program that they had called the Patient and Family Partnerships Program, and just from a colleague, and I joined, and basically it's a volunteer basis where you jump on any engagement. They send a newsletter of all the different projects that patients can be involved in, and it's with your own commitment through time, through locale, that you get to participate. And so that already overcomes one barrier of, as myself, I'm full-time working, I was in school, so how can I contribute to this? Now there's also honorariums for your time, which is even better, but I'm understanding that not everyone has that. And so with this model, this is a program that when you are in your clinical center for care, your practitioner can ask you if you want to be involved. There's posters all around the centers where you can get involved, and you get to choose what you interact with, what engagements you're on. And they also follow a model of engagement called the IAP2, which can go from informing, which is when scientists, researchers tell you what they're working on, to collaboration, where you're at the table, you are part of the project, you're part of the decision-making for what happens in your cancer care. And so for myself, I've done maybe over 50 engagements now in the past 2 years. It can be from what the landscaping or the artwork in the different cancer centers are, or it could be revitalizing the phone line, the appointments, how the workflow of these appointments happen. And so I think that if every organization can create this partnership program, slowly the culture will shift to and include and appreciate how these partners and these patients can bring in their experience. Like we said with the cars, for patients, we are driving the cars every day. Every time, every second we're outside of treatment, outside of the centers, we are having experience, and that is wisdom, that's knowledge. Maybe it's not scientific research knowledge for what genes are involved, but in the realm of patient experience, it's really valuable. And so if we can bring that model in and start to change the misnomer of how patients can be involved or what time that they are taking away or contributing from, I think it's important. And just to add that, I think the culture shifted with first bringing up patient stories. My story is on the SPAGN blog if you want to read about it. But I did some talks sharing my stories to the provincial health leaders. So I sat at tables with board of directors, all these different meetings to share my personal story. And I think when people, especially people in power, hear these stories, they hear that it's people that could be their own kids, their own partners, their own family members, they start to connect emotionally and understand that it's important to promote and advocate for that, both financially, in the budgets, provincial budgets, privately, and overall. And so now in BC, in Canada, we have a 25-year cancer plan, and it has patient-centered care as one of the pillars. And so we've changed the culture in our province, and that continues to grow and to be involved in every single step of the way. So this is one success story, and I would love for my province's cancer care to influence the whole world. I know it takes one conversation at a time, but yeah, I really wanted to share this because I know we had a lot of questions being brought up and some discourse around what we can do, what we should do around specific sarcomas to cancer in general. And so yeah, I wanted to bring that to mind, that there is success happening in this space, and I think we can continue that. Thank you.
Thank you very much for sharing that. And I think we've heard a real kind of spectrum of ways that patients can be partners in research. And I really don't want to end without hearing from Dr. Fletcher, how is it that you think, because you had some ideas, and I think it's really important in basic research, because we talk a lot about clinical research, I would really love to hear, even though I know we're a bit over, if you would share with us, please.
Even if it's going to be a downer? What can you do but fall short, after this, clearly it's not a time of stasis, right? This isn't a conversation we would have had 10 years ago. And just a couple of quick comments, and maybe I'll give two examples, but I could go on. We could go on easily for another hour or two, right? But I think that when the need becomes clear, the opportunity becomes clear, that cultural change can happen very quickly, and we've mentioned a few examples where that has happened. So again, the group, the national effort that Markus is part of, I think it took about a year, 6 months maybe, for the word to get around. If the advocates aren't involved at the ground level, then your proposal is going to be in trouble, right? And people wised up, right? And I don't see why, folks couldn't go to their local comprehensive cancer center and say, we don't see that happening, and other people are doing it, and it's effective, and it's really important. And you folks are going to start to look like you're kind of throwbacks, right? If you don't get on board, right? I mean, there's leverage to be had. So the question is, again, your point about you don't want to become an engineer, right? Like there's the aspect of the customer model in the car that doesn't quite apply because we scientists are like engineers, like how does the pathway work, right? But how do you have agency with science? And I could give a list of examples, but I'll just give two that come to mind. They may not be persuasive, but hey, it's about having agency, right? Well, this doesn't apply to everybody, the first one, but it's a real life example. Starting around 2018, the researcher, again, these are lab-based folks, working groups that I was part of. If there was a primary individual who was supporting the effort, like seed funding, then I would tell them at the outset, we're going to meet every month and calibrate our work, and I want you to be there, okay? Taking notes. And we'll sit down afterwards and go over them, and I'll explain it all to you, right? And they developed agency, right? Now they were, one was a high-placed lawyer, another was a high-placed business person, but they're doing incredible things for the field. They've developed that understanding and the motivation they had right from the beginning, right? So some people might be in that position and some people might not be, but it's been, and then the N of one that you mentioned, I'm going to kind of twist it a little bit, but the idea that it's not just about one person. SPAGN represents, of course, this wonderful plurality of different groups. Study sections, that's the review section when you've worked so hard on your grant for 6 months. And if it's in sarcoma, better yet, if it's a program grant that includes multiple, a ton of work, right? And then you go to the study section, there might be 30 reviewers, and 2 of them know something about sarcoma. And you're kind of dead in the water most of the time, no matter how important the grant is, right? You got to get lucky, right? Because these are folks who they're comfortable with other challenges, and they're up at 2 o'clock in the morning trying to get their review done, and it's just hard to get their arms around it, right? If maybe SPAGN already has this or in the works, but I'm talking about suggesting a rigorous process, a subcommittee, where an application like that would be submitted to the committee, and if you like it, then you would get behind it. You would provide a letter and say, here's why this opportunity, based on where the field is so timely, is so important, and it meets a global challenge. Yes, in my case, it might be a NIH, NCI, North American funding initiative, but this is addressing a global challenge. Imagine what an asset that would be. I mean, that the application has to be strong. You can't be putting your imprimatur, your endorsement on something that's a weak application, but that would tell people in other fields that within the sarcoma field, this is truly seen as something that should be supported, that should be taken seriously. So just one example where you don't have to be an engineer, but you'd have to understand enough about, for that sarcoma subtype, where the field is and who these investigators are, and is the question that they're asking one that resonates with you and should be strongly supported. If it isn't, then you shouldn't support it, right? You know, just like when we review other work, we believe in being straightforward about it. So I think, speaking personally and the groups I'm part of, that would actually be a remarkable opportunity if it's not already in the works. Is that good enough?
That's great.
Okay.
So I want to thank you all for kind of hanging in there with us. It's been a long day. John, thank you for stepping in and helping us out. We appreciate you being with us all day long, and for all of our panelists for your insights, and for all of you for sharing your thoughts. And it really is a community exchange, and I think that's what the unique value of coming together at this meeting is the opportunity for us to all sit down and have conversations. So have a lovely evening, and we'll,
I know we are going to over, but someone was waiting for a long time. Is it okay?
oh, thank you. All right, so have a restful evening, and we'll see you back tomorrow morning at what time? 8:15. 8:15.